And I am now very honored to turn this over to Angelica Lavito, who is from CNBC, and a stellar lineup of trailblazers delivering care that you're going to hear from today. Thank you so much, and thanks for coming to Minnesota.
Thank you. Well, thank you so much for joining us today. We have a great panel ahead. Looking forward to it. So first, we have Dr. Penny Wheeler. Great. All right, and then Lesley Solomon. And Dr. Susan Turney. Well, Penny, we'll start with you. So Dr. Penny Wheeler is the CEO of Allina Health, a $4.1 billion system that includes 12 hospitals, 65 clinics, 52 rehabilitation locations, and 2 ambulatory care centers across Minnesota and Wisconsin. She was once told she was too empathetic of a leader. As CEO, she's made empathy an integral part of Allina's mission. So you view your role as much larger than simply helping patients get physically well. So how do you view health, and what are you doing to help patients holistically?
Yeah, I think we got schooled pretty early by, I always said my best teachers were my patients, and so was our community. As a teacher, you know, we were told and taught that health is the absence of disease. And I remember one community member, an elder in our community, getting up there and saying, "You think this, but it's not that." You know, and so we try to think about what are more holistic things, and going from what's the matter with you to what matters to you as an organization. I often say that we're kind of on a hero's journey in this work. You know, we're going from a time where, you know, it's wonderful to be alive today. All of us out here, who I can't see, by the way, but I know you're there. You know, all of us have actually an extra lifetime from 150 years ago. You know, that's because of advances in care and advances in public health. We get an extra 40 years than people who lived 150 years ago. But I think that healthcare, well, it used to be simple, it used to be ineffective relative to today, but it was very relational. Today, we are doing wonderful things, but it's more episodic. You know, it's very complex, it's complicated, every episode of care, you know, it's something different, somebody different delivering. It's very fragmented, it's confusing to people, it's a hassle for many. So how do we actually refocus on all the innovative technology we have, all the advances we've made in the complexity, and actually add to it those relational things that have been lost? It used to be that somebody knew you and came to your home, knew all about your family, all about what was ailing you from a body perspective, but also what was your emotional state? What drove your spirit? What kind of connections did you have for the community? That's, I think, what we have to try to restore. So we're going back from making home a hub of care, I think, through technology means and through high-tech means. And I can give you a few examples as we talk about it, about how we as an organization are trying to do just that.
Wonderful. So that's a great segue into Lesley. Lesley is the Chief Innovation Officer at the Dana-Farber Cancer Institute, where she helps to bring their mission of high-quality care to the rest of the world. So, Lesley, let's talk a little bit about, cancer treatment, because as we talked about, it's becoming more personalized. So, you know, how are you helping that transition, and then how are you helping bring that treatment to the rest of the world?
Yeah, so I joined Dana-Farber a little over a year ago. I had been at Brigham and Women's Hospital for about 8 years before that. And in coming to Dana-Farber, I had really been blown away by the amazing care, the amazing science, the amazing high touch of the care that was being done. And I really felt that why limit it to just the patients that can come to Dana-Farber, that can come see doctors and clinicians at Dana-Farber. And I think about all the time, how can we take that care, take that science, and get it to patients, and get it to patients faster? And not just patients at Dana-Farber, but the patients in our communities, so the patients in New England, but how might we even think about expanding that to the entire United States or even the globe? And so, so my team thinks about commercialization and how we can turn the work that's being done into new products and services. And the way that we're starting to do some of this, we've done for many years, we've done this in the therapeutic space. So we've started over 30 companies over the last 10 years in the therapeutic space. But now what we're trying to do is think about what are the clinical protocols that we have, and how can we package those in a way that might allow us to deliver the care that's being delivered at Dana-Farber into the community. And then how can we also partner with the community hospitals to do, we have over 800 clinical trials every year at Dana-Farber, and how can we get those trials out to patients in our community? And what I look forward to is maybe not just getting those out to the community, not just getting them out to New England, but how can we get those out to the rest of the country? Because really recruitment in clinical trials is one of the biggest challenges in trials. So so anyway, so that's a lot of what I'm thinking about at Dana-Farber, is expanding the touch points of our care.
Great, looking forward to hearing more about that. And so Dr. Susan Turney is the CEO of Marshfield Clinic Health System. It's a private system with more than 50 locations across Wisconsin. She's not shy about treating patients who tend to be older, sicker, and poorer than others, and she's passionate about bringing innovation to rural communities. So talk to me about innovation. You know, how do you view it, and how are you trying to bring that to your system and your patients?
Sure. Well, you know, we really, we can't see the audience, but I'm just wondering how many people live in a town less than 20,000 people? Just the show of hands.
Wow. I don't see a
I don't see too many going up.
I see a couple over there.
Couple over there.
And how many of you who've raised your hands live in communities where a family of 4 household income is $40,000? And I suspect there's even less of you. So, in how many of you live in communities where you have 1 to 2 people working for every Medicare beneficiary? Minneapolis is 5 to 6, Madison's about 4 to 5. So I don't see many hands. So when you think about our communities, we cover about 40,000 square miles. We have a very poor, we have an elderly, and a population that has multiple chronic illnesses. So we have had to be innovative because we have such a vast geographic expanse, but we also have a unique population. And there are patients, and we need to serve them. There are only about 1.2 million people that live in our service area, so it doesn't sound like a lot. But again, when you think about the challenges that we have with where they're living, you can understand what that might be like. We've been an ambulatory care provider for over 100 years. And it's only recently that we've had to think differently about what it really means to be an integrated health system. And in the last few years, we've been acquiring hospitals, we've been building hospitals, because it's important that if we're going to deliver on our promise to meet the patient's needs where they're at, when they want it, and how they want it, we have to look and act differently than we have historically. But there are a lot of other things that we've done in our history, I think, that have set us apart as a large healthcare provider in the state. We, in 1957, created a research institute. And the purpose of it was really to do studies that will have an impact that can go directly back to the patient and how we take care of the patient, the value we provide, and the efficiency of care that we want to provide all of our patients. We also created a health plan in 1971, and there are many health systems that have provider-based health plans, but in a rural area it becomes much more complicated and challenging, making sure that you have the type of providers to really take care of our patients. In the last couple of years, what we've done to move patients to a lower cost service, just a couple of things that I will mention. One is we're doing cases in an ambulatory surgery center, and that in and of itself is not that innovative. But what we've done is we were doing complex cases in the ambulatory surgery center, and instead of having the patient recover in the hospital, because there are rules that don't allow recovery beyond 24 hours, we have a skilled nursing facility adjacent to the ASC where the patients go. And so again, that's not that innovative, but when we talk about affordability, it's decreased the cost of care 25 to 30%. That's a huge impact. The length of stay is down about 40%. The readmissions are also down about 30%. following these major surgical cases. So again, delivering on our promise to our community is challenging when you live where we live and the types of patients that we serve, but we've been able to deliver on that promise. And the second one that I'll talk about, and we can share more examples as we go on today, is our hospital at home program. Again, hospital at home is not all that new or creative. It's available many places of the country, many places of the world. But the challenge is for us, again, is living in a very rural community and making sure you have the resources to take care of the patients that we serve. So we did start the hospital at home program about 3 years ago, and we had 5 diagnoses that we limited to till we knew that we could actually do what we said we could do, which is take care of the patients as well or better in home rather than in a hospital facility. And it was so successful after 1 year that we expanded it to all diagnoses and now take care of many of the patients that would normally be in a hospital in their home. And the results, again, are the same in that less cost, patients are happier, families are happier, and the benchmarks that we use, which are typically hospital benchmarks around length of stay, readmissions, falls, are much better than you would see in a typical hospital. So again, what our purpose is to make sure we meet the needs of our patients where they want it, how they want it, and when they want it. So that's why being innovative in a rural area is a little more challenging, but the results are very positive, and we're happy to report the success stories that we've had.
Mm-hmm. So in terms of identifying patients' needs, how do you all go about doing that, and how is technology perhaps changing that?
Yeah, I can speak to it a little bit. I think about innovation on 3 levels. It's like, there's drugs and device innovation, there is care model innovation, and probably some payment innovation too that's going on. So all of those different levels, involve some innovation. One of the things that we're most excited about, in terms of finding out, really what really matters to somebody is like having conversations about what really is affecting their health. So we know even from a Cigna study, a big, huge problem in our country right now is loneliness and isolation. It's about equal to smoking 15 cigarettes a day. So how do you start to talk about what things are in people's lives beyond their disease states for that? We got a grant from the Center for Medicaid and Medicaid Services to look at social determinants of health. We're now screening people in our clinics and emergency rooms for 5 social determinants. Do you have violence in your home? Do you have food insecurity? Do you have a roof over your head? Or you have transportation needs? Or do you have problems paying your utility bill? And we rolled that out, and since June 5th have screened 50,000 people, and almost a third of them had one need in those areas. So it's our people learning how to have different conversations with those we serve and with each other, frankly. And then we have a wonderful thing called NowPow, which is in that software space that actually can connect people to those resources in their community. And we're finding that people, like I talked to one named Amber, she said that, we went from, just because her dishwasher got fixed, and or her washing machine rather got fixed, that was $10 more a week, that she could have to spend and actually fix the car that got her, son with epilepsy and one with cystic fibrosis to the doctor on time. I mean, she said we took her from the bottom to the top and made her family whole because we helped her with $10 more a week. Sometimes the margin is that narrow for people. One person said recently to one of the doctors, well, now I know you care for me. He said, I always cared for you. She said, yeah, now I know you really care. So connecting that high tech, this NowPow software with the high touch of, people feeling continually cared for, that's one of the things I think is most exciting for what we do. And doing that, we think will actually not only improve lives substantially, but reduce the cost of healthcare for our community as well.
Yeah, I think talking to the patients and understanding what their challenges are and realizing that there are solutions that are out there, but also it's about finding the right solutions. We were talking earlier about the article in the New York Times today about the Apple Watch and how it has a new EKG monitor in it. And the upside is that it might catch some things that you didn't know that were there. But the danger is the false positives and the false negatives. And is it going to start to increase the cost of healthcare because people are going to have these alerts that they've, had a situation when maybe they didn't, or it was just because they had an extra cup of coffee, or whatever that might be. And so I think it's really important to validate these technologies. And one of the things I'm looking forward to doing more at Dana-Farber, which I did a lot at Brigham, was bringing in these external technologies and trying to find the ones that work the best for your patients. And in the oncology space, we think a lot about adherence and symptom management. With the advent of all of these oral chemotherapies now, there's a lot of patients that aren't coming into the clinic to get their chemotherapy anymore, but they're taking that at home. And when those pills make them feel really bad, it's hard for them to continue taking it. Or they might say, well, I'm just gonna wait till, this dinner that I have to go to is over, and then I'll take it. And then all of a sudden, their symptoms get out of whack, or they're not necessarily taking it as much as they should be. So we're in the process now at Dana-Farber of prioritizing the challenges that our patients have, but also that our clinicians have, and then understanding what are the best technologies to help us solve those problems, whether they be wearables, whether they be some of the voice technologies like Alexa, or just a tracker to understand if they've taken their pills and if they're kind of on track. The other thing that we want to do is make sure that we're getting alerts, right? But alerts in a way that doesn't increase the workflow of the clinician. So how do you balance getting all of that new data with all of a sudden, how do we manage this? And so we're looking at things like chatbots, ways to, kind of sense if there's, if it's green or if it's yellow, if it's red, and then be alerted if there's a problem or if there might be a problem. And so again, it's really, I love, the hospital at home model, and I think it's brilliant. And if you can build up the kinds of tools that are needed to go home with the patient, to manage that time when they're out of the hospital, so that when they come in, you can manage them at that moment, and they haven't necessarily forgotten about everything that happened the 6 weeks in between their their treatments. And so that's what we're starting to think about at Dana-Farber.
We've had successes, and I've talked about them, but one of the challenges we do have is that many of our communities have no internet. So that is probably different than many other places in the country. Probably northern Minnesota may experience some of that as well. But despite that, we know that our patients are tech savvy. We know that they are demanding more. Their expectations are pretty high. So when we think about innovation in the context of what we do every day, it really has become one of our values, and it's really embedded in our mission and vision. Innovation can be very simple, wearing a Fitbit or other type of wearable that monitors your steps, to something very complex, monitoring chronic congestive heart failure. And I think the challenge that we have, and I heard it in what both of you said, is how do you get the technology that's going to work best for the patient population that you serve? And as I was thinking about how do you identify patients at risk or take care of people that are chronically ill, sure, you can push a button and you can identify all your patients with hypertension. But what it doesn't identify are the patients with hypertension, hyperlipidemia, heart disease, and renal failure. So how do you link those together and have the tools that can really help you best manage those patients? Because they're not actually in the healthcare facility much at all. Most of their care is being provided in the community. So we have to figure out how to loop back better with where they're being taken care of, in the home, in their faith-based groups, in their nutrition centers, in the Y, where they're getting exercise and nutrition counseling, and then use the wearables to augment that human touch, which I don't think anyone's saying let's eliminate, because I think ultimately that trusting relationship, knowing that people care, has a bigger impact than anything else. But we haven't quite mastered how to use all the stuff that's out there.
I think we're like 5-ish years. I want to say 5 to 10, but I'm hoping that 5. But where AI and all of the machine learning that we hear about is going to actually start to allow us to use that data, and that we can build some algorithms on top of it so that we can start to predict when someone's going to go into a failure, or when someone's, when something bad could happen. And I get excited about that time, because we know it's all happening now, but once we have we're collecting data now, but right now it's not structured and it's messy, and but once we can start to build that, add in the wearables, add in the electronic health record, add in the genomics, add in the metabolomics, all the omics, you will start to be able to build some learning on top of that.
And exciting, and I think the exciting thing about that, all the AI coming together, you know, and even with natural language processing, which we have had trouble extracting from things, and all of the other things that come in, is that then we can use our uniquely human skills, you know, to really actually make the relationship connections, because all the things that we're less enamored with as human beings, like data, you know, crunches that we have to do is already done for us, so then we can actually attend to those things that make the connections for the people. So it's going to be an exciting time. I hope you're right about the
5 years?
5-year timeline. I think that'll help us get in a much better place.
So AI is not a buzzword, it's an actual possibility to be used. And I guess when you think about technology, it sounds like there's a theme of trying to integrate technology, but also keeping that human component. How do we balance that? I mean, you mentioned if I have an Apple Watch and all of a sudden I think I have, you know, a problem, you know, how do you try and connect those two components?
Well, I think one of the things is we just have to remember philosophically, the tool is not the thing. The tool is not the thing. The relationship is the thing. If we can get to a state of healthcare where there's no discharges ever, nobody's discharged, everybody's taken care of, that's the thing. It's like when we all implemented electronic medical records. That wasn't the thing. We found out pretty early that was a tool, but it wasn't the relationship. And so I think that we have to make sure that we have that recognition that we cannot go through these ways of connecting things for people without the technology. It's critical, but it's not the thing, you know, at the end of the day.
I don't think anyone's going to ever come to us and say, oh, I had the best conversation today with the chatbot. So they're going to come and they're going to say, oh, my nurse today, she was so amazing. She took care of me. And so it really is, and we have these conversations a lot because the care and the human touch at Dana-Farber is really like, you know, what we call our special sauce. And how do you start to build in these digital technologies without letting that go? And I think, you know, to your point, if you can add it in and have that allow you to create more time or more availability to spend that human time with the patient, then I mean then you win, right? Like that's what so many doctors went into this field for. I'm not a doctor, but my dad's one. Play one on TV sometime. Kidding. But that's what clinicians went into this field for, because they love taking care of patients. And now they're just sitting there doing this all day. And so if we can give them that time back to do what they love, then everyone's going to win.
You know, it's really interesting because when we talk about the technology, it's almost like an evil word in a clinic. And when you're the CEO, your job is not to see patients individually, but to really help our providers be able to see patients in a better way. And when they're spending 4 and 5 hours of their day using electronic health record, doing order entry, and filling out forms for prior auth that add very little value to the direct patient care, and you see the burnout in not just physicians and providers, but even in the administrative staff right now. So it's something we just can't pile on. We can't say, well, now we've got the electronic health record, but guess what? We can now, you know, constantly measure this, and we can take the data from this device and put it across your computer all day. We can actually stream it live, so you can actually see what's happening in the home. So it's, you know, the challenge that we have is we have to figure this out, because the burnout rate and the suicide rate in physicians is very high. And I don't see a pathway right now to make it easier.
I do.
I
do.
And I hope we do. On the short term, I think we have some huge challenges. And we need to embrace the technology, embrace the tools that we can use to make our patients better, whether it's wellness, prevention, or sick care. However, we can't pile it on top of everything else they're doing right now, because the frustration is not excitement. Frustration is frustration.
Yeah, and I don't know how many startups, I don't know if there's a lot of startups or entrepreneurs here in the audience, but you know, one of the things that we dealt with a lot at Brigham and Women's when I was there was startups would come to us and they say, oh, we've got this great solution, we're going to solve all your clinicians' problems, and we've got this whole new dashboard. And I'm always saying to them, okay, so they have this dashboard, now you're going to give them that dashboard, and then there's this other dashboard. And so the first question I always have for every startup is, are you changing the workflow? Because if you are, leave, come back when you're not changing the workflow. And you know, it's sad that that's kind of the barrier to actually having this innovation work, but it's not going to work if you're going to change the daily workflow unless the impact is so big, which I haven't seen that yet. So
Yeah. No, I think that burden on caregivers is very real, and we have just added on. And I remember, feeling in practice. I'm an obstetrician gynecologist. I was a data entry person a lot of the time, rather than giving the kind of care we want to. So we always have to be attendant to that. And I think right now, I'm hoping we're in the worst of the pile-on stage.
I hope so
and
too.
Lesley, to your point, that we're going to get somewhere where we can do these things. We have. That mean more, like, for example, we now have an algorithm that predicts not only readmissions, but also predicts who's anticipated to be in the last 2 years of life and who needs more support. So that's great that the algorithm does it to us, but then we have like a human being, a care guide in this standpoint, that's actually an extension of the physician team, that actually goes and helps. And we found out that not only do people love it, they love being supported. By the way, only 20% of what they want to get connected with in terms of services has to do with their physical health. It's a lot of family, social services, it's a lot of transportation needs, it's legal services and those things. But we found through those care guides, which were an extension of the care team, first of all, as a physician, you felt like, oh my gosh, good, there's an extra arm taking care of these people who are so vulnerable right now and so needed. And then we found out too that they were thrilled with it. It was like angels on the earth to have these care guides connect with them at their appointments or in their home or call them to see how they were doing. And it's scalable because it was affordable. And by the way, we dropped ED visits by 25%, and it saved $900 per member per month for those people. So, there is ways in which you can use technological advances in this way, an algorithm that predicted this going ahead of time, offer these services to people that are very high touch, extend and reduce the burnout, because there's nothing worse than having a doctor know that I just let somebody go from my clinic and I don't know that I served them in the way that I would have wished to. And that probably contributes more to burnout than there's a lot of add-ons with technology and with electronic medical records, but that probably contributes as much, feeling like you haven't served a patient in the way you wish to.
One thing I would just add to this is that as a physician as well, my goal was always a good outcome for the patient. And when you actually ask the patients what they want, that's not what's top of mind for them. The University of Utah Health did a study recently that showed only about 30% of people believe that that's the most important thing. What they want is simple. They want access. They want compassion. They want to know you're involved with innovation. So, sometimes as people who are in healthcare, we have to tip the model on its head and start really asking the patients what they want. And all of a sudden, some of these pieces do fall into place, like you said. So it's not like we're generations away from solutions that will make it better for the people that we take care of, but it has to be a thoughtful, deliberative process. And it has to start with, what do people want?
Yeah.
I mean, we can do a lot of really, really good things, but if it doesn't matter to the patient, we've done a huge investment and haven't really ultimately served our purpose.
So what do people want today, and how is that forcing you to change?
I can talk a little bit about from the oncology perspective, and there has been some writing about this recently, but there are some amazing new immuno-oncology drugs that work for about 15 to 20% of the population. And patients come in and they say, I want this drug, I want to try this drug, but that drug, might not be appropriate for them. And so I think what patients want, and it's actually, the more that I think about it, it's precision medicine, right? And that's like the right drug for the right disease. But it's actually also, if you add on precision medicine, is the right care for me. Should I be at my home? Should I be in the hospital? Should I be, with my family? Another example is Dana-Farber's bone marrow transplant program. It's a pretty intense process having this bone marrow transplant, and for the first 6 months after your transplant, you have to come to the hospital once a week for 6 months. And then the next 6 months, it's once a month for 6 months. So imagine coming to Boston into a very high traffic area every week And if you're coming from Maine or you're coming from New York or you're coming from somewhere else, you actually have to uproot your family and do that. So, so part of it might also be, what we've been studying actually with a PCORI grant is how can we train the doctors, the clinicians in the community, and how can we develop protocols that actually work with the doctors in the community so patients can go home and they can be in their home with their own hospital, but going by the Dana-Farber protocols. And that's really an amazing experience that is based on patients saying, we can't stay in Boston, we can't be here for a year, we need to come up with another solution, and then build in the technology of the ability for the clinicians to talk to each other from different institutes, right? And so I think it's precision medicine from the human side, so like what I need for me, but also the ability to add in the science side and the ability to start to understand what drugs are the right drugs for the right patients. And so if we mix that kind of all together, I think what they really want is the precision treatment, right? Maybe?
Yeah.
I don't know.
Yeah, well, I think they do, and I think that something else that we're increasingly learning is, do we know what people really want? So we've had to bring, I don't think so. I think that we have to understand better from, the customers we have, what is really, important to them. We know some things from larger things in addition to like what's right for me personally, which I think is absolutely right on. We know that we look like a labyrinth to them. There's a huge hassle in healthcare. We're taking people at the most vulnerable, and instead of healing them sometimes, we're actually adding to the burden because they don't know where to turn or where to go.
Or how to pay for it.
Or how to pay for it. So it's costly, it's fragmented, it's reactive instead of, really anticipating things ahead of time. And then we're also burdened by the fact that our business model today actually doesn't necessarily reward us for keeping people well. It rewards how many things we do to how many people. So we're challenged by that. I think when you ask people what they really want, they want us to, again, to take that kind of hassle out of it and not to feel alone. I say that I'll know that we've arrived when I probably get 4 or 5 calls, Susan, you probably do too, Sue, about where should I go for this particular service. When we stop getting those calls, when people feel like they're connected and can find their way, then we'll probably arrive. But we've got a lot of work to do. At our organization, we realized that, and like many others, brought in kind of like we need a customer insights function to really start to, involve consumers in what they want and need, and actually even try to excel into what they want and need and solve a problem that they never even expected could be solved. But I was, recently I told some people I was blow drying my hair, and I ordered something on Amazon online, and then I went to a meeting, and our former CEO, of our organization, said that his wife had problems, and it took her about 5 months to coordinate the different providers she needed to get that problem solved. Wow. So the expectations of customers are going up, and they should, and our ability to meet them is going to lag unless we start to catch up in some of those ways that matter.
Yeah. It is really very interesting to me because, we did ask our patients what they want, but it's at one point in time.
Right.
Yeah.
So whatever's happening around them at that point in time is where they is where they're at. So right now, the talk is around affordability.
Yeah.
So they want cheaper care.
Yeah.
The talk is around access. They want it care in their schools and in their businesses and in their grocery stores and daycares and the why. So, but when you bubble it down and try to think about what they really care about, they don't want to waste a lot of time. They want to make sure that they can get what they need when they need it. They want to make sure that, the nuances of the healthcare system just don't resonate with them. Mm-hmm. And when we tell them we're decreasing the cost of care, and we have, it doesn't always translate to what comes out of their pocket, just because of all the changes that are happening in our world right now. So I think we have to be on this journey together. And it has to be a dialogue that is really meaningful. We can't pay lip service to it anymore. And I think we've done that in healthcare. It's okay, we'll fix that. And we can't do that any longer. Yeah. We really have to listen because these are people's lives. And it's not just health care. Like you said, it's their mental well-being, it's their physical well-being, there are cultural issues that we need to deal with. And if we don't really integrate better with all aspects of our patients' lives, not that we have to be responsible for it, but interact with it, I don't think we can be successful.
Although I would say if we address the clinician burnout thing, I think that will trickle down to the patients in a significant way. So if you could pick, maybe one thing to really address, that could be one of them.
Yeah,
but
I agree.
So you mentioned that you're typically interacting with patients at one point in time. I guess, how can we get consumers to engage more in their health? Not just when they're sick, but, either, like you said, we can predict when they'll be sick, or try and, get them to be more engaged in their health.
I wish I had a stat right now, maybe you guys know it, but what percentage of the population has a chronic disease, right?
Oh, it's huge.
Because I think about the ability to engage patients with a chronic disease might be, I don't want to use the word easier, right? But might be a little bit more logical than someone that's having an acute issue. And so if you could, kind of train patients and clinicians to engage when there's a chronic situation, it then kind of would allow you to escalate it, when there are acute situations. And so, and maybe the Apple Watch, again, not for all populations, but that technology could start to build in the ability to manage your daily, whatever it might be. And, there are apps and there are websites and there are, but we've seen so many people come in with pads of paper, journals of what's going on, and that's not sustainable. So, and that's engaged, that's very engaged, right? But we've got to be able to make it easier for them.
Yeah. It's hard to explain the purpose when you have hypertension and the downstream risk can be 20 or 30 years. So you say you've got to have good blood pressure control because you might get vascular disease, you may have a heart attack, you may have a stroke, you may have, need an amputation, but you're talking 30 years. So I think that's one of the challenges. I think with some illnesses, you can see the immediate effect. And I think patients are pretty good about engaging and good decision-making between the provider and the patient. But a lot of the chronic illnesses are long-term, the prevention and the treatment. So it's just one of the challenges that we have in healthcare. So if we could do all the prevention and never have to deal with any chronic diseases, it would be great, but that's not going to happen on the short term. But we do know from a lot of experience that in patients with congestive heart failure, for example, if they're in a congestive heart failure clinic, they do better. They live longer, they have less admissions, they're in the ER less, their quality of life is better, but it's a very intensive program. It requires a lot of people time, but that's really what we should be investing in if we're serious about our business. So how can you leverage the people that are in the facility doing the actual hands-on care with all the people that surround that patient? And that involves the technology, the other community resources and the things we've talked about. But it's that coordination and connecting the dots across all their spheres of life. So it's not easy. And then that's just one disease. Many of our elderly have 4 or 5 chronic illnesses. So you're also having to do that with their diabetes and their hypertension and their heart disease. So the nuances are many. So the more we do on the front end, the less we'll have to do on the back end.
And I think it's connecting that care for them, too. So I think we might have to migrate to, first of all, 80% of people that, migrate from end-of-life issues to preventative issues. 80% of people at the end of life want to die at home, but they're dying in our institutions. So what do we do there to, honor their choices, for care? And then I think you're right. People engage when they have an illness, more with the healthcare system. So what do we do to actually, make sure that we're engaging them in a way that connects our care team? You were mentioning, Sue, that, most elderly people have multiple chronic disease. I think about 50% of them have more than 3, and they have an average of like 7 providers. What do we do to connect that care? So, some of our colleagues will go, well, I can't do it because I don't have control over what that patient does, or they're non-compliant. I'd like to eliminate non-compliance, from our vocabulary because we're connecting the care team in an effective way for them. And then I think we can move thank you.
Like that.
And then I think we can move to, from secondary prevention for chronic illnesses, and that usually engages somebody. If you tell somebody who's diabetic, boy, we want you to walk around the lake with your grandson. We don't want you to be pushed in a wheelchair. It matters. And then hopefully we can move to the front end of prevention. But it's, I think we've got plenty of opportunities now with some wearables and other technologies and people's interest in measuring themselves to engage people. And how do we do that in a way that connects that interest with our care.
So we only have a few minutes left, so I guess my last question is, what are the largest challenges that we face today, and how do we address those? Give you a minute.
The largest challenges.
Are the ones that you think are the most pressing that we need to address?
I mean, I think we've talked a lot about the clinician burnout. I really do think that if we don't fix that, we're going to be in a lot more trouble in other areas. And we already are, we already don't have enough primary care doctors to fulfill the need. And so patients are going to the ER instead of getting, primary care and thinking about prevention. And, how do we encourage more people to go into this field when it's as challenging as it is? And so I'm going to stick with that as my biggest challenge.
Yeah, it's such a big question.
Yeah.
But I think the workforce.
Big ideas.
Yeah, big ideas. And it's not just the burnout, but it's really bringing people into the healthcare arena. We have a shortage of physicians, other providers. I was talking to a large health system out east this last weekend. They're short 52 medical assistants in a large urban area. It's hard to believe. I mean, I expect to be short on medical assistants because of our rural nature, or where we're located, and the fact that we don't have the ability always to recruit people to the communities. But we have some serious problems, so I think the challenge really is to reinvent ourselves in a way that we can accommodate all these missteps and the dots that aren't being connected, and really make sure that it's simple, easy, and seamless. And if we can figure out how to connect all that, I think we'll be in a much better place. Because we have some huge challenges, and if it were 1, 2, or 3, it'd be different than the fact that it's probably 10, 12, or 13 or more.
Yeah, I think you guys bring up great points, burnout and the connectivity for people. It's a target-rich environment, for what you have to do to bring this. And I think there's no better time to be in healthcare. I think the technology and, quite honestly, the capacity for human beings to actually do their best work has not been greater. The connectivity has not been greater than it is now. I would love to see us eliminate waste in the system that's not helpful to the people we serve. I think that's a huge thing, and the challenge there is it's somebody's revenue. Oftentimes. But I think that there's ways in which we can, eliminate things that aren't helpful to the people we serve and invest in things that are. That $10 a week and getting somebody to be able to have their washing machine fixed so that they can get their cystic fibrosis child to the clinic. And then I'll end with what I think is most important is one of my mentors, Don Berwick, a mentor to many of us, said that, he thinks that love is the most important thing about healthcare. Because if it's not one person or many trying to relieve the suffering of somebody else, and that's not love, I don't know what is. And I think that what we're trying to do is expand that notion by some of these innovative techniques to be able to do the work that drives us all to work every day.
Great. Well, thank you all so much. Appreciate your time today.
Great. Thank you.
Thank you.
Thank you. Thank you.